Did you listen to Jeff and Professor Hemo in the morning? Here's what you missed.
So mchana tu ni ile mlipeleka voluntarily. Wacha ingole. Unadugwa jirani unaambiwa gojeni hapa. Mnagojea. Baka mnaanza kuuliza maswali za watu huko. Ward 7 iko wapi? Unapeleka watu wa Ward 7.
Wanaona ni mtu hapo sasa.
Juu umekaa kwa hiyo hospitali. So
that is a really bad
situation. It is.
Yeah, people
afadhali hapo ni meno
10 hours and it's a matter of life and death.
Oh yes.
Now that is the conversation we want to have this morning. And we have experts in studio. Let me introduce them. Mr. Isaac Makaya is the CEO of Amerata Group. Asante sana for coming in. We have Professor Gituro Wainiana, Director General Vision 2030.
Used to be.
Yes.
Yeah.
Kabisa. Utatuambia because there's also an issue of healthcare in that particular instance. So we'll talk about how best to make sure that Kenyans get the best healthcare that is available. And last but not least, we have Mr. Mose, Head of Legal at the Amerata Group. Yes.
Thank you very much.
Asante sana for coming in.
Yes.
And I'd like to get your views on that feature. That's the first point, Professor. Waiting on health. When people take more than 10 hours to get medical services, what should be done to hasten this process, and what kind of impact does that have?
I think first is to perhaps appreciate that somebody goes to the hospital because you are sick. So it's really, it doesn't make any sense that I'm sick and I've been told for 4 hours.
Yeah.
It's actually so painful. And I can tell you, most people avoid that. And you find somebody, people who don't have the flexibility to go to the private, it's too bad for them. I can tell you for sure, I have to think like, should I go to this damn place? Because you'll be there.
Yes.
I think what needs to be done, and this is something I probably need to push, we need to get the model like the one of Cuba. It's no coincidence that the Cubans are here. Cubans, a lot of the resources are at the community level.
Okay.
So it's almost, before even you hit level 6, there are procedures you have gone through. And that's what has it. And it's like, those who can remember old enough, when we used to have extension officers, uko, you know, mashinani.
Yes.
Wanaenda mpaka kwa farm, wanakwambia hii boga umepanda vibaya. That's what we need the doctor as.
Yes.
And that's something we have not really worked on. That will now decongest the high level kind of areas. So you actually, before somebody is there, they have gone through a lot of process.
Oh yes.
And I think one of the things we need to take, and it is a very sad situation, is that is a devolved function. But I don't think we have taken it seriously.
Should it have been devolved in the first place?
Absolutely. Because health, it's at the village. Health is not at Nairobi. Because people out there. And I think in my view, you cannot deliver health from the headquarters. It's too important. I'm telling you, my brother, if I was not feeling well, kama huyu amesema mambo ya nini?
Yes,
meno. I could not come here.
Yeah.
By the way, you're right. I don't know why the tooth are so stupid. They actually come. During the day, they're okay.
Ziko sawa. Ni kama ulimi. Imesahau hiyo ni meno. Imesahau ni meno.
Usiku ndio inakoroga.
Saa 3.
I'm telling you, if you're not healthy, you can't. The other thing I think to address, probably people have not seen it, food. Food is the best medicine.
Oh yes.
If you eat the right food, you probably will not see a lot of people going to the hospital. And that is what we talk about preventive health. So we need to more concept of the preventive healthcare as opposed to curative.
Oh yes.
And those most people probably going to the hospitals will be going now for curative as opposed to preventive. And we can prevent a lot.
So we work with community-based resourcing, and preventive, rather than curative.
The Cuban model is the best you can ever get.
Very interesting.
You know, when we had the tool, there's a certain plant we used to get, and it was medicinal. Those are the preventive I'm talking about. We can address those kind of areas. Of course, now with the technology, we can now leverage on terms of I can get all the prescription without physically coming to the Kenyatta Hospital or whatever. And I think it happened about 5 or 6 years in Masabi when they had the first cesarean, and it was done through technology.
So they got all the information from...
Let's leverage on people like Safaricom. They have a very nice platform on e-health. And we can actually treat people wherever they are.
All right. Let's bring in Mr. Isaac Makaya to find out from the Amerata perspective. What do you think should be done?
Thanks a lot. as Professor said, preventive is more effective.
Yeah.
Going community healthcare is more important right now, because that's where you catch the people from the ground.
Okay.
That's where you prevent such waiting time. Imagine, as Prof has said, that there's a certain medicinal herb you used to take. Before you go for that line, you already know about it.
Yes.
There are community healthcare workers going around the villages, telling people this is how we need to do. What we eat actually makes us what we are.
Oh yeah.
So if this conversation goes ahead, actually a lot of these things we see in the hospitals will be captured early enough before them going to these critical issues like we saw yesterday in the newspaper.
Sad story, isn't it?
What about creating awareness of the capacities of the hospital to handle certain diseases, so that when I'm unwell, kama ni menu na niuma, najua this is where I should go to, and this is where I should go to kama ni masikio. Is that also one of the things that could
That is very key. That's
decongest certain hospitals?
Yes, I agree with you. That's where partnerships come in, the private and public come in. Even now, the use of the youth. You know, can you imagine 70% of our population are youth?
Yes.
And even the age group whereby the medical personnel, let's say from the lab guys and nurses, all these are the youth, and they're more energetic. Now, suppose we use them to reach out to everybody, give out information.
Yes.
And we as Amerata Group and the Ministry of Health, we are planning to have an expo like that to discuss this now. How do we synergize all these things that we know? I know the government has a good policy. Community health care is key. That is another discussion. We need to discuss it out. We need to tell people this is, our health is our wealth.
Yes.
Yes.
Lakini sasa the youth unajua ni wakula 2022 tunangojea tutakataka nao huko waeleweke.
Let's bring in Mose on this one and find out, because you're the head of legal. So what happens when somebody goes through such an ordeal? Do I have any legal recourse? Can I actually sue the hospital? Or what kind of legal threshold that do I need to prove that my patient died on the bench because I was not served efficiently?
Thank you very much. Of course, matters legal are usually very complex. It's not very easy to pin down anybody for that particular situation. But I think the conversation we are trying to have as Amerata Group is that we've organized for a conference whereby we'll bring all players onto the table that will be able to have this conversation as to not just about the delay, but also the quality of healthcare, quality of medicine, cost of the medicine, the entire 360 spectrum on healthcare. Because we cannot look at healthcare just purely from one perspective of a delay. Even the quality of the services you get as a result once in hospital is equally as important. Of course, as Professor mentioned, there's preventive component. There's the question, of course, of post-treatment care, the palliative care. Then eventually we are trying to make sure that if we can make healthcare affordable, then I think the entire nation benefits. Yeah, thank you.
Yeah, affordability of healthcare, that's the biggest challenge we're facing also, Prof. Because yesterday I was speaking to KMPDU Secretary General Umo Luga, and he was telling me that what we have in this country is a mismatch of the expertise and the human resources. So he says, for example, a clinical officer refers a case to KNH. The doctor at KNH is less qualified than the person who referred the case to them.
What?
So then now they have to redo the test afresh. He said this is something that happens practically. People just don't know about it. The person who refers the case is always more qualified than the person who will receive the case. And then now that other person who's received the case has to do their own tests because they can't rely on the previous test. Yeah. So how do we bridge that gap?
I think the first place, and Parliament, we're trying to do this strongly. I think it's something, and I'll be we are dishonest in this country. And of late you have people twinning with the doctors in India. So a case is supposed to be done here, you're told, you go India.
Yes.
But that's the point I was making earlier on. If we can train more the clinical people, go to the US, they have what they call paramedics. So they can do a good proportion of what you want to be done. So if you have qualified clinical officers who go through the MTC and train them well, I think what and you need a model where the triangle there, you have few doctors specialized, then most of here are clinical officers, well trained. And I think what I really doubt, perhaps in terms of, if you go to real doctors, and I'm really looking at the training they are going through, I can tell you, Nairobi University, not that I teach there, the doctors are good. Maybe it's these others we are getting here. But when you refer to that doctor, whether it's a cardio, whether it's a whatever, I think it's important. The other thing we want to get very strong in ourselves is to have a partnership with the doctors from India, other areas where they have specialized areas. And I think that will help us so much, because actually a doctor's time is very expensive. So most of the time spent with the clinical officers. And I probably train them pretty well. Pretty well to deal with those things. And I think what is important is to appreciate what the kind of, when you talk of medical, who is the target? It's not actually the youth. The youth are very strong. It's probably people at my age. Is it? At that area, kind of. And therefore, and this kind of people are in the rural areas. They are not in urban areas. So getting those clinicals I was telling earlier on, you can afford it. You can actually have them. I probably will not be comfortable to say the clinicals probably, the clinical officer could do a lot of things. But the specialized doctor can only do on this area. Like I know Professor Magoha, he has only one speciality. He can't do any other. But that speciality, he knows pretty well.
Because there's also an argument that what we should do right now is hire the doctors that we have. We have enough resources, we just don't have the
We have enough doctors.
Specialists.
You go to the SA, a lot of Kenyan doctors. I think what we have not done is appreciation in terms of this a critical sector. And I believe strongly something like health is something you cannot privatize. You have, as a government, to jealously guard it. Because it's so critical, as we are very clear in our group, Ahmad group, our health, our wealth. So in terms of then, and I've never argued in my views, it has nothing to do with the resources. It has none. The saga we have been taken over for the last 6 months, that money can do wonders in this country. It's not that we don't have resources, but I think we need to sit down as we are doing ourselves, step back, what are the critical areas we need to address? Then after that, let's look for the resources. If you have a good plan, you guys, nobody will stop you.
All right.
But I think we need to and look at the First Lady. How she has reached every part of the country. Does he have extra money?
No.
And she's doing what people should have been doing.
What the government needs to do.
Correct.
Yes.
She's doing that. So I think that's issue about the resources. The issue of the doctors, I think let's deploy our doctor appropriately. We have enough doctors in this country. We have about 4 universities actually. Moi, Kenyatta, Nairobi University, they're all producing doctors.
And yet we are way below the WHO recommended golden finishing line.
Absolutely.
Which is 1 to 1,000. One doctor
Because
to
we
1,000 patients.
are a society which is not honest. That's the bottom line.
Yes.
We are dishonest with ourselves.
We are dishonest in ourselves.
Right.
I want to go there. I had an opportunity and I go somewhere and somebody say, to do this, you need to require budget something like 400,000. I go to another doctor, you need to budget 50,000.
So everybody has different quotes. And it's
No,
the
no,
same
it's-
thing.
Seriously,
Shilingi.
400, yes.
Yeah.
Besha.
Ni Nedewa.
No, ni plot.
Yaani mtu anakuona hivi anaona kamulu.
pesa.
Anaona kamulu. Huyu ni chapa.
Anaona maguta.
Ni maguta.
So I was like, do I need another opinion?
Oh yeah.
And this is what we are trying to do. Because most Kenyans, they will actually say, if I want a new opinion, I'd rather pay the ticket, go to India. Which is so sad.
Yes.
But we want to bring India here. So that we can partner with the Kenya government.
Yes.
So you can do those diagnostic kind of tests. But yet,
We've also had instances where people have been misdiagnosed.
he's a living example.
Yeah.
Maybe should you actually tell us?
He's an actually living example.
Let's bring in Mr. Isaac Makaya.
Yeah, that's a different
You can also tell what really happened, and you can also tell us how do we leverage on technology to ensure that people are served better.
Correct.
You can come close to the one. Yes.
No, Prof.
You don't have to. You don't have to mention the hospital.
I'll leave you here before you. So that quite there at the end.
What happened to you?
Let me start like this.
Yeah.
Usually, the best way to treat is to diagnose well. You get diagnosis well,
Yes.
Yeah.
you've done it.
Yeah.
So, as Prof just said, I went through some serious issues.
Hell. Just say hell.
Yes. 4 years ago, I had some back problem. I didn't know it was back problem. I was limping. You have a back problem and you are limping.
So ukajua shida ni mguu. Yes.
Na kawaida ni shindano. Pain inapotea.
Basi.
2 weeks later, it becomes worse.
Madawa mengine.
Madawa. There's a time I was given 11 tablets a day for 1 month.
And nothing happened.
What are you eating?
No,
Anything
no.
else?
No.
You want to improve ama bado?
By the time namaliza, I can't walk.
Correct.
So it made it even worse. You are limping
Because
now, you can't walk.
We are dealing with something about you here.
See here.
Yes.
Much later, I go to Parklands here, to a small clinic. Doctor lies me down, touches me like this, tells me, listen, you have a back problem. There's a nerve impeding. Just like that, after 2 months. Nothing, he just touched me.
And that's it.
Then I started now the treatment. So I had to go because I didn't want it was to involve some procedure.
Yes.
Personally, I didn't trust. So I had to go to India.
Oh yes.
India, they didn't operate. They did some physio. Came back. I had a relapse. Went back to bed. To say the least, diagnosis, if it was done, because the damage was done for the medication that I took for the first 2 months.
Yes.
So that medication made it worse.
It made it worse. From then, we have a passion now to look for solutions. And we know solutions are here. Kenyans are sharp. The best doctors we have gone abroad or are here.
Yes.
What we need to do is come on the table and say, listen, what is it that you want? How do you want this to go? And the government comes on board. The government has some beautiful policies.
Yeah.
The only thing is, we want everybody to sit on the table. Wait time. How do we handle it?
Yes.
What is the cause? If we know the cause,
Yeah.
then we have the solution.
Yes.
And the solution, Kenyans, we are sharp.
I like what you say about sitting around the table, because this is the same concept that was used for the medical equipment scheme, a multi-billion shilling scheme for the counties,
Yes.
and then the medical equipment there is just gathering dust.
Yes.
No one to use them,
No.
no expertise. Some places there's even no electricity.
Listen, there are countries out there. Even here, people, we need to train experts. Before even we do anything, we need to know who is going to use it.
Yes.
Okay. Now, in this conference that we organize, I'm going back to that because that is what we want to have a conversation towards that, so that we don't just mark time every time. And this conference is totally different because we don't want just to have a conference. We want to have a follow-up. Deliberately being followed. After 2 months, we come here to the studio and say, this is what we've done.
Yes.
This is where we've gone. These are the trained personnel. These are the clinicians that we were talking about, that now they're taking major chunk of work so that the experts are left to do the expert. Like, I remember, is it a year ago, when the government said there's no need to go to India for kidney? Yes, why do you have to go? Why do you have to go? Yes, the dialysis machine. Sometimes we glorify things out there. It is us, we have the solution.
Which we already have.
We need just to sit and say, we have this one here and this one here. How do we now manage it?
So how do we leverage on technology to ensure that we have the data of what we have? Everybody knows that if I go to this hospital, this is the service I will get. If I go to this other one, this is what I'll get. And they are experts there plus equipment.
IT, digital, the technology that we have right now can give us the information that we want. It's only managing it. Manage it well. As Prof said earlier, some of the organizations, Safaricom, and some private organizations have that. Kenya, I remember when you were the Vision 2030, won the award for what? Digital health. Was it in 2000 something? We won an award for digital healthcare. What happened?
And I think you can't.
Yes.
I think technology is so important. If you read the Nation today, Jeroge of Central Bank has written an article on fintech and AI, artificial intelligence. I can tell you now, like this, and it's so sad. This colleague passed in Kibera. He was told and he was even told how many days you have to live in France because of technology.
Yes.
And that's the same technology we are talking about. It can go to the machinani. And I think the point you pointed about power is there. We're talking the last mile. If you look today, you can reach everybody in M-Pesa. Why can't we reach everybody using the same platform in health? And I think the issue of the equipment, and I think perhaps you need to bring it clearly, the equipment was an easier way of getting funds. Yes, that was an easier way. What's the best thing? I get a whole equipment here, it's at but we are not using it. And I think what Isaac is spot on, you first train. Even take the people to where it's coming from, train them, they can even come with the equipment. But you don't just buy it, because that's an easiest thing to do, procurement. And then you have it there. I think what is happening down the road, and I think this is something we need, technology will have to take us. Blockchain, we're talking about the 3D printing, we're talking about that. It's going to. And I think what we need is to prepare ourselves for it. And I can tell you some of the areas. I'm in charge of Kenya School of Government and the chairman of the council. And I can see the training is still like, hey, you people, we need to come here. We need to. Yeah, we don't have to come here. We can communicate the whole country from one point of view. And I've always given this example, probably around me to go to education. There's a lady in Pangani, she teaches maths well. Students get an A. Why can't she teach the whole country?
Through technology.
Through technology.
Yes.
Yeah. So there is no, this one is this one is this. The same teacher can teach everybody. The same thing to medicine. If I'm diagnosed of kidney failure in Mombasa or whatever, or Kware, I can actually get the best advice from the doc here in Kenya and Nairobi Hospital.
Without having to come here.
Absolutely.
Yes.
Absolutely. And that saves you a lot. The pain, coming all that distance. You have to pay for the fare. You have to, the one you're saying earlier on. Unapigwa shidano halafu mnagoja masaa manne. Something like that. So I think it's important that we leverage on technology. It's something, it's here. We can't run away from
it. And it will help us. Kwanza hii mambo ya misdiagnosis.
Ni technology kama hii yenye nimeshika hapa. You get everything here. Hapa tunaweza ona right on time right now 10 minutes ago Collins Owino. Alisema ask Gituro.
The other thing happening actually, most people are unfortunately not in the rural areas. Before I go to a doctor, most people are Googling.
Yes.
So you're talking to me.
So self-diagnosis.
Yeah, you're talking and I'm looking.
Yes.
So you tell something. No.
Hiyo na confirm. Squeeze hakuna kudanganya.
And I think that is something we are talking on about head start. What is all about.
Trevor, I'll tell you something. Yes. My late dad alikuwa misdiagnosed. Akaambiwa wewe you have HIV. Hata akapatiwa ARVs. For 3 months amebeba kwa mfuko. Anaangalia kama my mother. Anaangalia my mother anashindwa. Nani mama? Wakati tumezeeka.
Iko kitu siamini.
Yes. You see, ukisema nisiende India na nilimisdiagnosewa. Unani explain aje? Kama kenda if you misdiagnose me here. Hata uniambie nifanye nini? Vile tu ulifanya. The same way you went to India. You did not care. We need to work on
what we need to do is now the board has to come out and be very strong.
Yes.
If they get somebody like that, the license is taken.
In fact, yes.
That's what we need to.
And maybe
but the board is there.
Mr. Steven should tell us about this, because legally speaking, what options do Kenyans have on this kind of situation? Because we've seen a lot of instances of misdiagnosis.
I think the biggest challenge with matters of giving evidence in court is that we'll still rely on the same doctors to come and give evidence against the fellow doctors.
And they will not rent out.
And that has always been a challenge. But I think with introduction of technology, as Professor mentioned, artificial intelligence,
yes,
those are things that would, in a sense, be able to gather the necessary evidence which could be presented in a court of law to probably penalize a doctor for professional negligence. And I think a lot of this information is not out there. Members of the public are not aware that they have that option of pursuing doctors for any negligence, because rightly or wrongly we look at doctors as demigods. So whatever they say, you walk into a clinic, they tell you remove your clothes, that's the first thing you do. You don't ask questions. So you can imagine that's the same person who tomorrow you're attempting to sue in court. Already you're approaching it from a point of view of
I'm suing a god.
Yes, in a matter of speaking. But beyond that, I think there's something you mentioned about information to the public. I think we need to relax our regulations on doctors and medical personnel from being able to advertise their services. If that can be relaxed a bit, then people can have more information as to who is specialized in what, which clinic does what, which clinical officer is able to do a certain line of medical care. If that conversation can be had at a certain level from the professional bodies, and agree that it's high time to move away from the so-called nobility, whereby your reputation should speak for yourself. Let people know, in this day and age of Googling, let people know what exactly you're able to do. And that will help a lot.
Even with the lawyers.
Even with lawyers.
Even with the lawyers.
The law started, there's been relaxation on that. There's limited ability to actually advertise your services as a lawyer. We've not gotten to the level of the US where we are selling and hawking our services. But at least you can actually, come and check on which lawyer is able to do what. Yes, which I think is an important conversation. We need to move with technology, move with the times, let the people know what is out there.
Like what Professor said, we need to be honest with ourselves. In fact, Geoffrey, nasema devolving healthcare is better than when it was managed centrally. We have witnessed sophisticated machines in most of the counties than before. We just ask governors to do the right thing. And then we also have another question here for you from Collins Owino. He says, ask Gituro what they're intending to achieve in health in the remaining 11 years. Since Vision 2030. Unicam boy. I think tuchukue break arudi ajibu hiyo. Sio professor. That's a sample from Collins Owino. Because Vision 2030 was done. And the concept ilianza over 10 years ago. Tumeona nini this far?
Yes.
Did you listen to Jeff and Professor Hemo in the morning? Here's what you got.
Testify against another doctor. Anasema kanyagia. Unbelievable. We have Duncan Were. He says, I remember losing my brother at KNH. Pole sana Duncan. He was brought in by ambulance from Narok. Reached at around 4 p.m. Waiting in the queue to get attended and see the doctors took us almost 6 hours. He died at around 11 p.m. All the way from Narok, back at KNH. Isaac, this is why you want to have this conversation on the Africa, on the Medical Expo and Conference 2019, so that we get these issues before they get out of hand. Like for example, Duncan Were's brother was moved from Narok all the way to KNH as a referral.
Amefika badala ya kwenda straight kwa daktari ni ngojea kama watu wengine
6 hours. Na ameletwa na ambulance.
The evolution of healthcare is very key now. We need to make it work. You see, if there were services offered in Narok, there was no need for them to come here. We need to empower the counties, the referrals, the local hospitals, so that, you see, if we deal with preventive early enough, such things can't happen. But when they happen, we need to have solutions there on the level. We need to work on transport, like now we have a component of ambulances. Are our ambulances well equipped to handle such? Do we have trained manpower to handle that? Yes, we do. But do we have coordination? All solutions we have in Kenya, I'll tell you this, everything that we need is here. It's just to have a conference, sit down and discuss. How do we prioritize which one on this? How do we connect? How do we network so that we can handle such things before? The story for yesterday sometimes is very sad. It's very sad. What is the cause of that? Is it because we don't have human resource? Is it? That's a question I'm getting back. Is it? You know, these are conversations, these are questions we need to ask ourselves. Why is it that is happening all through? And I like the push now that the Ministry of Health is taking now.
Yeah.
We need, they have become, they are proactive now to sort this issue. Imagine all this time now they want to make it happen. Because the population is growing.
Yes.
The needs are growing.
Yes.
You see what happened 3 weeks ago about the issue of food. Now that is also the conversation we need to be having. What do we eat?
Yes.
How does it play with the ultimate health? How does it act with the economy at large? You know, sometimes we don't really correlate that health plays a big role on what the economy is going to look like in the next 10 or 15 years. 2030 will need Kenyans who are strong. And the ultimate aim, our thinking is, and I think that's the thinking of the government, is we need to keep Kenyans here, bring Africans here. And I don't see the reason why we cannot achieve that. The medical tourism that is going abroad, all of them, right now we are hosting a lot of them from our neighboring countries. They come for medication here.
Yes.
And us, we are running out.
Because we do not believe in our healthcare.
Can you imagine the neighboring believe in us?
Yes.
So
More
those
than
are the
ourselves.
conversation we need to see. Why is it that other neighbors are looking at us? What is it that we don't do well to make our people realize that indeed we need to capacity build this? Spending here for our medication, empowering the clinic officers, the personnel, that is going to help. And that is why this conversation needs to go ahead. It should not be the healthcare issues like now it's the talk of today.
Yes.
It should be at least weekly, because we are alive.
Yes.
Tomorrow we are not.
Yes.
Today you are healthy. Tomorrow we need to be discussing about this continuously. It is not a one-stop shop. We have to go all continuous so that we make our country have universal coverage, healthcare coverage.
And Prof, this is part of what Collins was asking earlier.
Yes, Collins,
We
yes.
commissioned Vision 2030, 10 years down the line. We haven't achieved much, 11 years to go. What happens now?
I think,
Where are we?
I think I'll come to Collins, but I think there's a very important point here. If you ask most people, what's the most thing they fear? It's bad health.
Yes.
That's most people fear. Somebody says, I would rather have nothing, but have good health. And I think it's a very important discussion here. Now, 2030, I think one thing perhaps I would probably be academic here. 2030 was, it's not really the end of it. So we still there, like Lapset, probably Lapset, Lamu, South Sudan. We can't finish 2030. It has to go on. Health is a continuous. I think if you look in terms of the key targets in the health sector, I think one of the things we have not done very well was medical tourism. And that was a key flagship. One of the things in medical tourism, 95% of Africans go for medical tourism, they pass through Nairobi. So they pass here and then they go. So we're saying, why can't we just hold them here? That will mean a lot. It will mean a lot. They need accommodation. We need boga from Nyandarua.
Kabisa.
So it's a whole ecosystem we create. And perhaps the Kenyatta University Hospital was built for that purpose. It's easier to move from the airport using the bypass to there, and taken some time, but now it's it's on feet. And I think Mugeda can push it on. Now in Vision 2030, in terms you look of the healthcare, and I'll probably talk now. I'm no longer there anyway, Collins. So I left in the end of 2016, but I'm still a Kenyan. Very clear. We have a target, Vision 2030.
Yes.
We dropped the ball. The Vision 2030.
That is the plain truth.
Yes, we dropped the ball. And when I reflect on nostalgia, working with the Kibaki, working with Aura, you loved what we were doing. Now we have PDU. We have the vision. It has been there without a director general for I don't know how many years. I think in terms of health, we need to see it from the First Ladies Initiative. At their initiative we can do. But more importantly, and I want to give two examples, and that's what will make us get the health. It's Kibwana and Guinea. They have managed health in their counties. Why can't we as governors do the same? And I'll give you an example. The governors went to Makweni for benchmarking. Yeah? I think this time we were not happy because we were out of the country. And Kibwana facilitated a dam which costed 8 million. I think the governor for Siaya said it costed him 80 million. The same dam, the same length, the same depth.
So why was one more expensive?
Correct. It's because I'm not taking due diligence. So healthcare, you can do it even before 2030 if you take it what should be must. It was the only thing which is fully devolved. And it can be done from the counties. It can. And I'm very optimistic. If you look at the key flagship was emphasis, as we have talked here, about preventive. And that, and the two things are linked.
Yes.
If you look at SDG 2
Yes.
and you look SDG 3, SDG 2 is on food and nutrition.
Yes.
SDG is on health. They're intertwined. You can't do one
Without
the other. And that's a key thing we were focusing on the vision. Even before the SDG came, it was very clear in our Vision 2030. What I can say, we need to go back to the vision, get the vigor we had, because there are opportunities that will transform the lives of the Kenyans.
All right.
Yep.
I want to give you a chance to give a final parting shot very briefly because we're running out of time here. And Professor, I'll start with you just to tell us what now is the way forward as we wind up this discussion.
I think I've said this before.
Yeah.
We need to have a no-nonsense approach to how we do things. You mess up,
Yeah. You go home.
just go home.
That is very true.
I think that to me is the bottom line. I'll put with this example. Somewhere in Africa, a brother to the president was to do a road. Then people complain the road is not as wide as we thought.
Yes.
So the president came with his people and they measured the road. And it was actually about 10 meters, it was 8. That brother is in jail as we talk.
That's how serious.
Simple, yes.
Yes.
You were supposed to do 10.
Yes.
The road is 8.
Yes.
So why should we holding you?
Ignorikula.
Yeah, that's the chance.
No nonsense approach.
This thing of Waitito should now be talking what you're talking when he's already in due process being done, he's in remand. As the due process is going on, he's in remand. That's my passion. So that will get to any sector you think in this country.
All right. Isaac,
Yes.
your final parting shot.
First, let me thank all of you for inviting us here. We want to invite everybody to come for this event on 28th August to 30th at Nairobi Hospital Convention Center.
Yeah.
And all this we've been discussing because we have partnered with the government, private sector. We want them to sit together and have a discussion. And the people who are going to attend, we're inviting all the council of governors, which means every minister from the county, director of health, chief officer, the private sector. Let's have this discussion. And we bring all the academia, these university hospitals that are training the doctors.
Correct.
We need to have this discussion ahead. And the private sector that are manufacturing the drugs are doing the diagnosis. Let them come on board. So that all of us as Kenyans, we have a one way going forward. Then the difference with this event is this. After the event, that is when work starts. Because from Amerata and the partners that we have formed, we will be monitoring now. Partnering with the government, also the monitoring and evaluation. Because surveillance is very key. We discuss, we stop. We wait until next year, another thing. In Kenya, we want to have a culture whereby we hold ourselves accountable for what we have spoken.
Oh, yes.
If we do that, the honest part that the professor said that we are not honest ourselves. We need to weigh ourselves of what we have declared in meetings, that every 2 months we have a report. This is where we are. And this waiting, the clip that you did yesterday, needs to reviewed next month. Are there improvements to this? Then
So
you
that
liaise with the
people are
government
accountable.
so that it is not just an expose. It is an input now. If this can be done, this can go ahead. So that we collaborate. With collaboration, we can go far.
All right.
See, the media, the government, the private sector, all of us.
Come together.
And remember, the youth are very key now.
All right.
Thank you.
Stephen Mose, you get the final word on this.
Thank you. I think from the conversation, it is clear that the nation's wealth is directly and correlated to the nation's health. A healthy nation brings forth a very wealthy nation. I think that's my parting shot. Let this conversation continue. Health is a very key component to the growth of this country.
All right. Short and sweet. Asante.
Catch Jeff Koinange and Professor Hamo every day, Monday to Friday from 6 a.m. to 10 a.m. only on Hot 96.